Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Alexander Saw. Dr. Saw is a native of Fremont and was born at Washington Hospital. Dr. Saw completed his bachelor's degree at Haverford College in Pennsylvania. He completed his internship at Massachusetts General Hospital and his residency at Harvard Combined Orthopaedic Residency in Boston. Dr. Saw completed his fellowship in minimally invasive and revision hip and knee replacement at Rush University Medical Center in Chicago.
We're going to cover everything I can in terms of updated treatments for knee pain, knee arthritis, and both the non-operative and surgical management of that. So just as a little bit of background, as you heard, I was indeed born and raised here in Fremont. My parents raised me here, and my father was a head and neck surgeon here for 40 plus years. My parents, if you know them, they still volunteer at the hospital. So they have a deep commitment to this hospital and this community, and that's why it's a great privilege for me to come back and do the same. I went, as you already heard all about this, Haverford College, and then where I trained in Philly and then Boston and Chicago, but then I've been here since 2008. This is actually a picture of my dad, if you don't know him, and this is a picture a long time ago when I was just a youngster, and then something happened in between. Now we've changed in terms of who's taller. But he's actually here in this room. It's obviously great to be in the community, to work with the colleagues that he worked with, see patients that he's seen. It's just been a real privilege and honor to, again, work at this hospital and then in this community. And I appreciate the recognition. I do not do my job or work for awards, but this means the world to me because the community has recognized me, hopefully for doing a good job like my dad did. Again, it's always fun when I see a patient, they say, I remember your dad, or he took care of my kids, or he took care of me. Again, nothing warms my heart more than that. So I'm trying to provide that care in the same personal way as he did. So what do? I do total knee replacement, I do total knee revision, I do partial knee replacement, and I'll introduce you to that today if you're not aware of what that is, and I do total hip and revision surgery. With the amount of surgery that I do here, I'm very fortunate that allows me to be co-medical director of the Institute for Joint Restoration. I'm actually director of the Outpatient Joint Replacement Program, and I'll talk about that more later as well, but all of these other committees as well. So what's nice is that I'm able to be involved not only at this hospital, but on a state level and with national organizations. So I continue to travel to lecture to other surgeons, give talks at other meetings so that I can talk with my colleagues and bring all the most up-to-date information and surgical techniques back to our community here. So I find that that's very important to do. And this is just one example of an honor that I received last year where our National American Association of Orthopaedic Surgeons selected 10 orthopedists in the country, and I was fortunate to be one of those to be involved in their leadership program last year. So we traveled around the country, and again, they were basically grooming us to be the next leaders in the field, so I appreciated that. So I'm going to cover a lot of information, as I said. Some of the handouts you have this website on it. Definitely take a look at it or write it down, because if I go too fast or you want to refer to it later, a lot of information that I'm going to present here will be available on that website. There's also a phone number there if you need to make a call, or on the website you can call us for more information or to make appointments. So again, this website will have a lot of this. So this is what we're going to attempt to do. It's a daunting task, it's a lot of information, but I'm going to try to keep it interesting for you if I can. So we're going to cover knee arthritis basics, just introduce you to the anatomy and the function of the knee. We'll talk about non-operative treatments. We'll talk about knee replacement, traditional versus less invasive surgery, partial knee replacement. We'll talk about our unique joint replacement program here, rapid recovery surgery, and then even outpatient joint replacement, something new and on the cutting edge. So first we'll talk about knee arthritis. So here's a diagram of your knee. And what you can see here is your thigh bone is on top and your shin bone is on bottom. And that white covering is just like the white covering on the end of a chicken bone. That's what cartilage is. You can see the ligaments around the knee. You can see the meniscus inside the knee. That's extra cartilage between the two bones. So this diagram depicts all the anatomy around your knee. Does anyone know what this is right in the middle of the knee? ACL, very good. So that's your anterior cruciate ligament, so ACL. That's what you read about every day in the sports paper. Some athlete ruptured their ACL. Right? This is the ligament that they're describing. So it's called the anterior cruciate ligament because cruciate, it crosses. It crosses the posterior cruciate ligament behind. So there are two ligaments there. One's anterior in front, one's posterior in back. They're called the cruciates because they cross. So they're in the middle of the knee. They're major stabilizers of the knee. But all of you have probably heard of the ACL. Again, that's the most commonly injured ligament you hear in athletes. So this is the side view of that same knee. And again, the white is the cartilage being represented. Here's the kneecap in front, that bone there, and this depicts the patellar tendon, and these white things on the side would be the ligaments. So if you look, this gives you an idea of what happens every time you walk or you go up a stair. That knee bends, and you can see anywhere there's contact of one bone against another, there's cartilage there, because that cartilage lets the bone move freely and without pain. So cartilage is your friend. That's what you want on the end of the bone. You do want to know that the knee does feel 3 to 5 times body weight, and even more with jogging, more like 7 times. So for every 1 pound lost, it's potentially 3 to 5 pounds of force off a painful knee. So just something to keep in the back of your mind. When we talk about arthritis, we're talking about simply the loss of cartilage at the end of the bone. So instead of having that white covering, it starts to get degraded, like the picture on the left, so that the exposed bone underneath is now there. And when bone starts to rub on bone, that's more painful. On the bottom left, you can see how the white is smooth, right? Like that chicken bone. That's good cartilage, intact cartilage. When it becomes pitted and eroded, that's what we term as arthritis. Usually due to wear and tear, sometimes can be due to trauma, sometimes can be due to inflammatory arthritis like rheumatoid arthritis or lupus or other things. But most often it's simply wear and tear. So the question is why does the joint wear out? Well, let's make the analogy that your joint is like a car tire. Why do some car tires wear faster? Well, maybe it was bad quality rubber to start with. Maybe it was set up to wear, like this tire. Maybe it had to do with the driving habits of that person in that car. They went very fast, they made a lot of turns. Or maybe like a freeway, the low frequency, lower weight left lane tends to not break down as much as the right lane, which is used more often, higher frequency, and higher weight trucks. So just in how much it's used, you can imagine one may wear out more than the other. And some of it may be genetics or genes. But the bottom line is arthritis means breakdown of that cartilage. Like here, the bone is exposed underneath, and so now it becomes a painful joint. Even though we're talking about knees, I do want to take a moment to notice that some people will have knee pain or pain in their knee area, but it's actually not generated by the knee. Meaning some people will have hip arthritis or hip pain, and it will refer to their knee, and they'll feel it in their knee, but there's actually nothing physiologically wrong with their knee. So it's always important for physicians and doctors to evaluate the entire patient, the entire person, because it can be misleading. As an example, I had a patient a year ago who came in who had 2 knee replacements somewhere else. And he came in on a walker. And for 2 years, he was undergoing every test, trying to figure out what was wrong with his knees. So for 2 years on a walker. He came in, he saw me, we reviewed his examination, and what I discovered was both of his hips were extremely arthritic like this. So for those 2 years, doctors were looking at the wrong body part. I fixed his hips and his knee pain went away. So just bringing up that not all knee pain means it's coming from the knee. Now, knee arthritis, what does it look like? Knee arthroscopy is when you use a small camera, and just like the picture on the top left, and you can go into the knee and look with high definition and another small instrument to clean up a small amount of cartilage. That's knee arthroscopy, using a camera and small instrument to clean up the knee. Well, these are pictures of what a knee looks like on that camera. So on the bottom left, this is very magnified, of course, but the probe is in the knee, and you can see the rounded portion on top. That's the end of the thigh bone on top. That's why it's rounded, because it rolls on that bottom flat portion, which is depicted here in the lower part of the picture. The part in between is the meniscus. So most people who have an arthroscopy have it for a torn meniscus. You're looking at a meniscus right there. But the reason I brought this up was to show you what arthritis looks like on the pictures on the right. So this here, the white remembers the cartilage. So this is a big defect of cartilage missing, a big pothole, if you will. And here you can see cartilage is tearing, pinkish, that's the bone exposed below. All of these are pictures of cartilage breaking down. That's what it looks like on the camera. This is what it looks like in the operating room. So these are the ends of 2 bones. These are the ends of the knee, the end of the thigh bone. Remember that cartilage should be white, should be smooth. These are areas where cartilage has been broken down. It's shiny like a cue ball because that white protective layer has simply worn away. That's what it looks like in the operating room. This is what it looks like on X-ray. So on X-ray, only dense things show up, so only bone shows up on X-ray. So as you're all learning, this is the thigh bone on top and shin bone on bottom. Remember, the white cartilage covers the ends of the bone, but cartilage is invisible on X-ray. So the way we know there's cartilage is if those bones are separated. So this space here is because there's cartilage on the ends of both bones. So what does it mean when the bones get this close together? It means that that cartilage just can't be there. It must have been worn away. So it's the absence of space that lets us know that that cartilage is wearing out. But we see some other things in this X-ray. So I'm going to ask again, anyone have any idea what's going on? There's a staple and a screw. What's happening in this knee? Anyone want to throw out a guess? This is actually related to that ligament we were talking about before. Remember the anterior cruciate ligament? Well, when that tears, orthopedists try to reconstruct it. How do we reconstruct it? We take a cadaver graft, we take hamstring, we take patellar tendon, we take some sort of tissue and put it back in that knee in the same orientation. So see these tunnels, if you will? You can imagine that that's where that tissue is going. So what happens is, because the ACL is deficient, we take tissue, drill a hole through the shin bone in the orientation of how that ligament goes, put the ligament across the joint, put it through the thigh bone on top, and then fix it with a staple or a screw or something. But then what's happening is that cadaver or host tissue is mimicking the function of the ACL. So what this means is, by just looking at this X-ray, I know that this patient ruptured their anterior cruciate ligament at some point, had some sort of injury. They had a reconstruction of some type of their ACL, and now they're bone on bone. And now you can tell that too. In 30 seconds, you can tell a lot of this patient's history just by that X-ray. But the bottom line of arthritis is we don't have a cure yet. Once that cartilage breaks down, we don't have a way of growing back normal cartilage or filling that space which has been ground down. So it's sort of like that car tire analogy again. Once that car tire ruptures, it's time to replace it. So that's the knee arthritis basics, and then we're going to talk about how do you treat that. So if you have knee pain, whether it's from knee arthritis or from some other injury, the first thing that you can do for it, of course, is rest. The mnemonic RICE, rest it, ice, compression, and elevation. Just for any body part, that often helps the occasional ache and pain. But for pain that persists, Motrin, Advil, ibuprofen, many of you probably have this in your bathroom or kitchen cabinet. This is a non-steroidal anti-inflammatory drug. Everyone here is familiar with steroids, right? That's a very powerful anti-inflammatory. These are drugs that have an anti-inflammatory effect but are not a steroid. They don't have any of the side effects. So Advil, Motrin, ibuprofen, Celebrex, aspirin, these are all examples of NSAIDs or non-steroidal anti-inflammatory drugs. They help with pain, they help reduce inflammation. The only caution you have to have is that they can upset the stomach. So if you have reflux or heartburn, sometimes it can aggravate it, or if you get ulcers, and that it also can thin your blood a little bit because it affects your platelets. So if you're on Coumadins or Orthopaedics, you have to be a little careful taking this in addition to it. But it's a great over-the-counter medicine for pain and inflammation. I give it to my children, it's very safe. Aspirin is another anti-inflammatory. Many of you may be taking that now, not so much for its anti-inflammatory effect, but for its protection of the heart, but it is an anti-inflammatory. Acetaminophen Tylenol is different. It's not an anti-inflammatory, it has no anti-inflammatory properties, but it is a mild pain reliever, and it helps reduce fever, as you all know. For someone who has arthritis, someone who has pain for any reason, Tylenol is another over-the-counter medicine which is very safe to take. It does not affect platelets, so if you are on Plavix, Coumadin, Xarelto, what have you, you can take Tylenol safely. The caution you want to have with Tylenol is that if you have liver impairment, if you have a diseased liver or any problems with your liver, that's when you have to be cautious with Tylenol. But if you don't have any other contraindication, you can take Advil and Tylenol in the same day and stagger them. They're safe because they have different mechanisms. They work in different ways. Now, if those don't work, some people will go to analgesics, things like Tylenol with codeine or Tramadol or Vicodin. But of course, we don't want people to be on pain pills. If your pain is bad enough where you require narcotics or pain pills, you need to have it evaluated because there's an opioid epidemic in this country, and there are downsides of being on pain pills long term. How many of you are taking glucosamine, chondroitin sulfate? Good number. And it's very popular because what it is, it's a natural compound found in healthy cartilage. It's not approved by the FDA, it's not a drug, it's really classified as a dietary supplement. The reason is there's no clear evidence to show that it actually does anything. There's no data to show that it regrows cartilage or anything else. And because there's no regulation, when you buy a bottle on the counter of the pharmacy or the GNC, you don't really know what's in bottle 1 or bottle 2, just so you know. Now, one of my mentors in Boston gave me a great analogy, which I will never forget. Because glucosamine is a building block of cartilage, he said that the analogy of this working is sort of like a bald man who eats hair, right? So just because you eat what you want doesn't mean your body is going to process it and put it back where you want to. So I will never forget that. But again, if it works for you, there's nothing wrong with it. It's not a bad thing. You just might be losing some money, but there's nothing really, no harm can come from it. Just no data to really support it either. Same with these supplements. There are a lot of these. It's a multi-billion-dollar industry. So there's a lot of money in it. People in the United States buy a lot of this. Joint juice, Arthro Gold, all these things. They sound great. Unfortunately, no data to show any of them actually do anything clinically. But again, if it works for you, it's okay to take. Physical therapy can help because they can work on strengthening and range of motion. Those things can help an arthritic knee in terms of function, but of course it doesn't reverse the arthritis process. So it may make someone feel better, function better, but it's probably going to be short-lived because eventually that arthritis will worsen. But the most important thing to take away from this slide is the last line. The benefits are lost within 6 months of stopping that exercise. So if you do the therapy, if you do exercise, remember it's something you have to continue. Don't stop it or else you lose the benefit. Now let's say all of that doesn't work. Now what do? Well, that's when you come see a physician and now you move to something a little bit more invasive. Only knee injections, but still invasive. The most common injection is probably cortisone. As we talked about earlier, steroids are anti-inflammatories, very potent anti-inflammatories. So it can reduce swelling. It can reduce pain. We typically mix it with a lidocaine, which is like Novocaine at the dentist, so a numbing medication. Put it in the office. It helps with pain. It's an anti-inflammatory, but it doesn't cure arthritis, and it doesn't last forever. For some people, it might last a couple months, some people a few weeks, some people a few days. So it's highly variable. But for some people, it can help, particularly if they're going to go on a trip or they're just not quite ready for surgery yet. But it's not something you can do regularly forever. You can't do one every 4 months for the rest of your life. So it's a temporary fix. There are some downsides, by the way, with cortisone, that if you do too many, that cortisone can start to affect the good parts of the knee as well. And that's why there are limitations on how many you can take. But if that doesn't work, the next thing you can try is viscosupplementation, or this gel. See how on the picture on the left, that material is very thick, it's gelatinous? The idea of this is it's a lubrication, in that it can be injected into the knee and potentially act as a shock absorber, if you will. It'll reduce some pain, reduce some inflammation. However, it's important to know that our Orthopaedic Academy does not recommend this. Not because it causes harm, but again, there is no data to show it actually does anything. It does not cure arthritis, it doesn't grow back cartilage, and some studies suggest it's about as good as injecting saline or water into the knee. But again, some people get it, they say they feel better, can't argue with that. But just so you know, there's not good data to say it actually has any clinical benefit. The third option, and a newer option, are biologics, PRP, or stem cells. You've probably heard about it. It's a very hot topic in the news. It's interesting areas of research, but we're not quite there yet. We don't have the ability of taking your own stem cell, growing cartilage, and putting it back. We're just not there. But PRP is what, again, sports athletes are doing. You hear about Kobe Bryant or these other people going to Europe to do these injections. I can do them for you here. It's taking your own blood, spinning it down, filtering it, and taking growth factors and other things naturally in your blood, and then injecting it into the painful joint to hopefully stimulate some repair and reduce inflammation. Again, not a lot of data about how well it works. It's new, it's being investigated. It's also not covered by insurance because it's so new. But some people have done it and have said they've had good results. So it's just another option to be aware about. Lastly are these devices and gadgets. You've probably seen these, you've heard about them. That middle one in the bottom I think is called the Willow Curve, and a lot of people have seen it because I think it has a celebrity promoting it on TV. But all these things, again, no data to say it necessarily does anything. I like the one on the top left, the Arthritis Killer. That one sounds very, very interesting in effect. But again, we don't know. It probably just works because it provides some heat or other things, but you can try the gadgets. If they work, great. Again, you might just be throwing some money away, unfortunately. So once all those things don't work, now that's when we talk about surgical intervention. Knee replacement, it's a little bit of a misnomer. It's not cutting out the entire knee and replacing the whole knee. It's really a resurfacing of the knee. But we call it total or full knee replacement because it's resurfacing the entire end of the bone. So if you remember those pictures before, if this is your thigh bone, you can see how this metal cap caps the end of the bone. But it's really just a few millimeters thick. So here's an example of a component. It's a few millimeters thick, and the idea is that when this goes onto someone's knee, it recreates the same size, the same shape, the same depth of what that knee looked like when it had cartilage. So these comes in all different shapes and sizes so it can be mixed and matched to that individual. But you can see it's pretty narrow, it's pretty thin, and it caps the end of the bone. And then what happens is a platform goes on the bottom, the picture on the right, so metal again, and then plastic in between. So what happens now is you have metal rolling on plastic, so instead of bone on bone. So this gives the opportunity to get rid of any bone-on-bone articulation and also to correct any malalignment of that leg. So Someone asked, what metal is that? And the bottom piece, as you pass it around, you'll notice is pretty light. That's titanium. That's what the plastic fixes to. The top part's actually surprisingly heavy. That's cobalt chrome. And the reason is that cobalt is less likely to scratch. And because the metal is what's rubbing against the plastic, you obviously want that to be very smooth, because if that metal gets roughened, it will act like sandpaper on the plastic below. So that's why there's a difference in the two weights. One's titanium and one's cobalt chrome. So in this picture, this part here, cobalt chrome, this bottom part is light, it's titanium. So what's it look like on x-ray? Here's a knee replacement going in surgery in the middle, the implant on the right, and then on x-ray. There's our arthritic knee we saw before, bone on bone. This is what it looks like in the front. So from the front view, metal on top, plastic in between, metal on bottom. This cloudy white stuff is the cement. And when you look at the side of the knee, it's again metal on metal with the kneecap in front. So that's what it looks like on x-ray. So how does knee replacement work? Well, people do well. It's typically something like a 12-week recovery. People are walking, biking, swimming, typically pain-free. We expect fewer than 1% to fail per year, meaning that at 20 years, over 80-90% should still be working well. How many knee replacements are done in the US? Over 700,000 every year, and it's expected to exponentially increase because of the baby boomers. So this is a very common procedure. This is traditional knee replacement. Traditional knee replacement is a pretty big incision, exposing the knee, putting in those components you're passing around, staples, using this. This is called a CPM machine. It's a machine you put your leg in and it moves the knee for you, and then walking on a walker. So traditional knee replacement, nothing wrong with it. You can do a great knee surgery through it. It just may not lead to the fastest recovery, right? You can imagine trying to heal this kind of incision could take a little while. So people who have traditional knee replacement often are in the hospital 3 or 4 days. Many go to a skilled nursing or rehab facility, and many are on a walker or cane for a number of weeks. Traditional knee replacement is fine, it works fine, but are there some advantages of less invasive surgery? Minimally invasive surgery is doing that same procedure, but doing it through much less soft tissue trauma, less muscle injury, less bleeding, less pain, hopefully for a faster recovery. And so that's what I've been doing here since 2008. That's what I was trained to do. So on the left is that traditional knee exposure and the incision, and on the right is what a less invasive surgery is. You can see it's just much less invasive. So doing that since 2008, I was constantly trying to modify how I was doing things in terms of improving pain, a multimodal pain management. So I try to focus on using many different medications to improve pain without using just a narcotic, for example. I try to avoid narcotics, try to avoid any high dose of any one particular medication to give a better overall result. And I talk to a lot of surgeons and around the country about how to do that, and I'll talk about that later. But I was working on better blood preservation, minimize bleeding, minimize pain after surgery, and then enhancing those rehab protocols. So what that led to was in 2014, I started a new program here where all my patients were walking the day of their knee surgery. And as a result of that, I was able to get my patients home the very next day. It had not been done here before. So I've had 40-year-olds and 90-year-olds go home the day after knee replacement. The bottom is my study on that, presenting it on the national level and showing people how people can do very well with these protocols. This, I just have to show, is a 95-year-old man on his first post-operative visit, 2 weeks after knee replacement. 95 years old. Pretty impressive. Now, what can knee replacement do? Certainly it can fix the very simple, but it can fix the very complex. Look at this gentleman. He's one of these who walk in and you know what's going on before you even take an x-ray. I mean, you can see through his pant leg what's happening. His knee, not only is bone on bone, but you can see how in the picture on the left, the x-ray, it's shifting out of place and he's actually eroding bone. But with this technology and the knee replacement, you can make that leg straight again. You can put it back to how it's supposed to be and take away bone on bone. Even in those patients who've had knee replacement before. This is a picture of someone who was referred to me. Their knee replacement was in there for 20 years and it started to fail and it was collapsing. You see how crooked her leg was. But with revision surgery, we can rebuild it and make that leg straight again. So that's the kind of things that we can do with total knee replacement and revision knee surgery. Now I'm going to introduce partial knee replacement. So partial knee replacement is very similar to what we talked about, but it's refined to only one part of the knee. So remember, total and full knee replacement is called that because it resurfaces the inside, outside, and front of the knee, all 3 compartments. What I'm talking about now is a procedure that only resurfaces one of those 3 compartments. So here, as opposed to the very far right, where arthritis is diffuse and spread throughout the knee, now we're talking about a knee where there's only arthritis in one part. So the question is do you need to replace the whole knee in that situation? Maybe less is more. So that's what partial knee replacement is. So it's still metal on metal, but you can see it's isolated to only one portion. The potential benefits of partial knee replacement are many. It's less invasive. It's bone conserving. It's ligament preserving. There's less blood loss. The knee has a better range of motion. It's a faster recovery. And because the knee keeps all of its ligaments, it can feel more normal than a knee replacement. It can be durable for up to 15 years. And in that rare case that it fails, it can easily be converted to a total knee replacement. I learned in Chicago how to do partial knee replacements, and that's what I've been doing here since 2008 in the appropriate patient. Because as well as knee replacements can do, studies have suggested that partial knee replacements can actually have even better results. So in the comparison of partial to total knees, these studies have shown that it can be superior with better motion. Patients prefer it with improved results compared to total knee, but only in those patients where it's appropriate. And to know if you're appropriate is you have to be evaluated by someone who does them. So there are a lot of patients who go to surgeons and ask if they can have a partial or total knee replacement, but if that surgeon only does total knee replacement, they're probably not going to offer you a partial knee replacement. So if you think that you may be a candidate, you want to see someone who does them and is experienced in them to see if you truly are a candidate there. This x-ray on the bottom right, hopefully everyone can see that. The total knee replacement you're becoming familiar with is on the far right of that bottom right picture, right? The metal, plastic, and metal. You can see how on the left side it's metal, plastic, metal again, but notice the middle of the knee is preserved. And for the third time bringing up that ACL, you're all becoming experts. You all know what lives there, right? The ACL and PCL. So with a total knee, because it goes all the way across, those knees are typically sacrificed. You don't have it anymore. Total knees can accommodate for it. They can work very well. But this is one of the major benefits of a partial knee. Those ligaments are untouched. So the partial knee, every native ligament of the knee remains. Typically, partial knee replacements, the inside of the knee, like this model here. So you can see again, it's metal on plastic on metal, analogous to what you're passing around with a total knee, but it's just on one portion of the knee. That's one type of partial knee. A partial knee can also be on the outside of the knee. That's the second compartment. The third compartment is the kneecap area, which I'm showing here. So some people, particularly women, can get arthritis of just the kneecap. So the kneecap glides in that groove every time the knee bends. But with bone-on-bone arthritis, like in these pictures here, this can be resurfaced separately instead of replacing the whole knee. But again, you have to be a candidate for partial knee replacement. So you have to be seen and evaluated, because if your arthritis is more diffuse, a partial knee replacement may only fix part of your pain. But you want to be seen to see if that's a possibility, because there are many benefits. I do a lot of partial knee replacement. I'm actually the United States lead investigator for the Zimmer Company's new partial knee that was just released this week. In terms of the partial knee implants, I actually, with this particular component, the company has told me that in last year I did the most in California and actually top 13 in the United States with that component. And for the kneecap only replacement, I did the top 5 volume in the United States. These are 2 pictures of one of my patients, partial knee, double partial knees, and this is him surfing in South America. And then this is a patient of mine who sent me this picture of her scuba diving in Hawaii. Looks like they're living pretty good lives. I'm envious. I'm now going to talk about our Institute for Joint Restoration, so the unique program we have. Prior to surgery, we emphasize a lot of education so that people can be educated by our therapists, our nurses. Our patients attend the class even before they've had surgery so that they know everything they need to about surgery. It really helps the recovery. There's no surprises. This is supplemented by an educational binder, which has all the information about what to do before, during, and after surgery. So we really do stress education. Our personnel, we've done fellowship training, our anesthesiologists, our OR techs, our nurses, therapists, this is all we do is joint replacement. So really everyone in every facet is an expert at their particular field. This is our facility. If you haven't seen it, the top floor is our office, and the office there is just on the top of that Center for Joint Replacement building. So it's on the top floor, and then on the middle floor is where our joint replacement recovery suites are. So here's the nursing station. There are 30 private rooms, so every patient has their own individual room. The only patients in that entire building are healthy, elective joint replacement patients. All the sick and ill people are in the main hospital, so we quarantine the healthy people away. But that also means that the therapists and nurses are also only dealing with healthy patients. So everyone in that building, the goal is to be as healthy as possible, to prevent infection, to prevent complications. And that's why we've been rated very highly, which I'll talk about later in terms of safety and infection reduction. With the number of surgeries that I do, I'm able to present the data that I do here at national level meetings. The AOS is our National Orthopaedic Academy meeting, publish these things in our orthopedic journals as well. So I am very involved with the research and presenting the data here on a national level. And these are just some examples of talking about joint replacement of different sizes and different knees, or the results of cemented hip replacement, or using gender type components, which was a female type knee design. So all these things get presented, and these were just some other talks that I gave last year at our National Hip and Knee meeting. So I enjoy doing that. I think it benefits my patients here. Fremont is here, obviously you all know that. While we are a local community hospital, we actually do draw patients from a large geographical area. So I've had patients coming from Hawaii and Washington State, New York, and Texas. And these people are coming here because of our program, because of the building, the therapist, the team, and everything from top to bottom in what we do here. So again, while we're a Tri-City hospital that's represented here in this blue, the majority of my patients are coming from other places. And that's a great privilege that they're willing to drive past many other hospitals to come here. So we take that responsibility very seriously. We've been recognized in terms of our orthopedic facility. This is a survey by patients. They've consistently rated us one of the top, actually in the country, in terms of satisfaction. And Becker's has reviewed our Washington Hospital and their joint replacement program, again, one of the top. And with health grades, you can look online. 5 stars is their highest rating. For hip replacement, highest ratings. Knee replacement, highest rating. We were their top joint replacement center just a couple years ago in California, so we get a lot of recognition. But people often ask about this in terms of safety. Consumer Report, maybe a year and a half ago, did this to look at the safety of hospitals in California. And what you can see there on the top left is Washington Hospital got the highest report for safety in knee surgery, higher than Stanford and UCSF, and we were one of only maybe 8 given their highest rating. And then for hip surgery, we were one of 5 Consumer Report's highest rating. So in terms of safety, infection reduction, and other things, we're one of maybe 2 or 3 in the state to get Consumer Report's highest rating. Next, we'll talk about rapid recovery surgery. So no one wants to have surgery, but if they do, they want to get back to doing what they want to as quickly as possible and as safely as possible. Typically, as surgeons, we've historically only been focused on the surgery because that's what we love to do. But with more and more time, surgeons are realizing with education and meetings and other things that you have to look at the whole picture. If you really want people to have a good experience, you have to look at everything from selecting the patient, patient education, pain, nausea, bleeding, to rehab, to support system, to follow-up. You have to look at all these things to have rapid recovery, and you have to have something in place to maximize that. So that's what my emphasis is. I actually give lectures and talk at national meetings about how to optimize this for other surgeons and other practices. So the goal is not only to be sufficient at all of them, but hopefully to excel at some of these. Because if you can excel at some of these aspects, maybe some of these patients can even go home the same day. Now that's not everybody. You don't want to send everyone home the same day, but if you have the things in place to allow that, clearly that will benefit those other patients who do have to stay longer. And I always tell other surgeons when I lecture them that all of these things have to be functional. If even only one thing is not working well, the patient will not go home same day or next day. So you can have all the aspects of care very well controlled, but if their pain is not well managed, right, they're not going to be able to recover quickly. And that applies for every other aspect of this. All of them have to be running on all cylinders to be successful. So what do I do that's a little bit different for pain management? Again, it's an emphasis and focus of mine. I employ multimodal pain management, so using many different medicines at low doses to give a better overall effect. And that's been shown to reduce the amount of narcotics needed, to reduce the amount of side effects from narcotics, and that's something that's very, very important. In addition is reducing blood loss by using special medications, special devices, special techniques. There's less swelling and less pain for these patients after surgery. But avoiding narcotics is key. As I alluded to earlier, there is an opioid epidemic going on in this country where there's more addiction, more abuse than ever before. As physicians, we have a responsibility to try to help stop that. Because if you look at this database study in 2012, over 1.6 million patients who were in the hospital and treated with pain medicines, 3 out of 4 were getting narcotics only. And that's actually a staggering number because there are so many other medications we can use that don't involve narcotics that we as clinicians need to do a better job at reducing the amount of narcotics we dispense. But the reason multimodal analgesia can work is because pain is actually a very complex pathway. There are multiple ways to intercept that pain. So traditionally, like I showed you, most people would just get morphine or narcotics, and you just keep getting more and more. But here you can see you can intercept pain at the site of injury, so example where the surgery is. You can intercept it at the nerve that goes through the leg, so with a block or anesthesiologist can do regional anesthetics. They can have spinals or epidurals. Anesthesiologists, again, can help numb pain before it reaches the brain. We can use various types of medicines, Tylenols, anti-inflammatories we talked about before. There are many different medicines we can use to reduce pain before we even try a narcotic. And this is just an example of a multimodal protocol that I wrote up in terms of how to best manage people's pain around joint replacement and how to avoid those narcotics. And these are some examples of some webinars and some lectures that I've given about how to try to do that. Because again, it's very important, both for the safety of the patient, but also to maximize their recovery. So this is my typical multimodal protocol. Something as simple as Tylenol, you would think would not help a lot during a major surgery like joint replacement, but it actually does. In combination with other medications, it actually reduces overall pain and narcotic usage. There's also an intravenous form of acetaminophen which can be used. So Tylenol and acetaminophen, same thing. The intravenous form may be even more effective at reducing pain, so I can use that. Or these anti-inflammatories which come in pill and injection form, or even nerve-type pain medications like Lyrica. All these things in combination can give a better overall pain relieving effect. I also depend on my anesthesiologist. I work closely with them to give blocks of nerves or spinal or epidural anesthesia so that there's less pain. People don't have to have general anesthesia when they have surgery here. I try to avoid that because it's less medication, right? Less side effects of medication. People being intubated means you're paralyzed and a machine's breathing for you. With these regional anesthetic techniques, some people will watch. 10 to 15% of my patients will watch their own surgery, believe it or not. But even for those who don't, what it means is they're breathing on their own and they're getting less medication, which will hopefully be less nausea and other things. This is an example of a novel medication I brought to the program here, that I brought to the hospital about 3-4 years ago. It's like Novocaine, which you have at the dentist, but it's made in such a way that it actually is released over time. So what I do is I inject it around the knee or hip at the time of surgery, and then the medication's in these bubbles, as you see in the top right. And what happens is it bursts over time, and this graph shows how the pain medication is in the system over 3 days. So what's nice is I can inject that medicine around the surgical site, help numb the area for hopefully 2 or 3 days, and that's not without even giving any medication yet. So that's the nice thing. So local management of pain first. And these are some clinical trials which I've run here with my patients and actually studying these things objectively to make sure there is true data to show that these things work. And so far it has shown that it actually does. We've seen it clinically, but it's always nice to have the data to prove it. This is just a quick example of a medication that I use around surgery which helps reduce bleeding. And with less bleeding, there's less pain and quicker recovery. Or various techniques I have in the operating room, again, to reduce bleeding. I even use something simple like this, which is a special type of suture. Who would think that suture could make a difference? But this suture is nicked or barbed, like you see in the top right. And what happens is this engages the tissue, so no knots are required. What that means is that there's less foreign material in the wounds, and that these incisions are closed watertight. So it speeds recovery and helps reduce infection. So I brought that here a few years ago, and it works very, very well. So this is what a typical knee incision would look at a few weeks. The picture on the left, 6 weeks or middle, and 12 weeks on the right. So no staples, nothing to remove, everything dissolves under the skin. And then on top of that is this dressing. So this dressing I brought here maybe 5 years ago. It's different than the typical tape and gauze that you put on. The problem with that is with tape and gauze, you change it every day, it rips the skin, it causes blisters, it's not very sterile. This is a sterile dressing that goes on in the operating room at the time of surgery and stays on for a week. So patients can shower right away. No one's touching the incision, it's staying sterile, we hope, for multiple days. So all these conveniences add up. So if people are able to shower, they don't have to worry about drainage from their incision, they're able to move and do their therapy right away without worrying, all these things add up to success, which lead to something like rapid recovery joint replacement or even outpatient joint replacement. Outpatient joint replacement, going home same day of surgery, is here, and it's happening. It's hard to believe, because when I was in training again, just a decade ago, joint replacement patients were routinely in the hospital 4 or 5 days on a walker for weeks and going to rehab. But now we're talking about people going home hours after surgery. These are some lectures that I've given at our national meeting in terms of my results with same-day surgery or on presenting my data on the rapid recovery results. So here is a small video of partial knee replacement. It's resurfacing the inner, outer, or front part of the knee only, so an isolated portion. You don't want to watch, just look away. But you're not going to see any blood because there's a tourniquet, and the knee looks that yellowish color because there's a antibiotic film that we use to prevent infection. You're just seeing the knee because the rest of the body is covered with sterile sheets. They have a regional anesthesia, and so they're numb waist down. They may even be watching or even talking to me during their own surgery. We're dressed in these gowns to stay sterile, but as I mentioned before, orthopedics is simply carpentry of the bone, so I'm using all my gadgets, I'm using my tools, my saw, my hammer, my drill, to just take away a little bit of bone to put in those implants that you're passing around. So this procedure, this partial knee replacement, takes me about 50 minutes, 50. So I can do it quickly, and then these patients will get up and walk and go home the same day. So this person on the left had the kneecap replacement, you can see here, and he had the inner knee replacement. This is them walking. This is a few years ago. This is when I started my same-day partial knee replacement protocol. This is them walking a few hours after surgery. they're going to walk and go home. So that was a few years ago, and I've been routinely doing that since 2014. So they get to come in the morning, have their partial knee replacement, and then go home. So people can do very well with all those benefits we talked about. Now, total knee replacement's the same thing, but it's just a little bit more invasive, right? Because you're resurfacing all the surfaces of the knee. So here you can see, here's that drill. So you can imagine that that might sting a little bit. So you have the drill, we have various guides. We use these things to help align the implants where we want to put them, but you can see it's a pretty small approach. Again, I want to make sure I put in the best long-lasting knee. I wanted to have a good long-term result, but if I can do it with a less invasive technique, beneficial to that patient potentially. But you can see I'm using my saw, I'm just trimming a few millimeters of bone to make space for that implant that you've passed around. This surgery takes me about 60 minutes, 1 hour. And same thing, like I told you, since 2014 they've been walking day of surgery, and then this is what they would look like the next morning. So they are going home 24 hours after surgery. Some using a cane, some using nothing at all, as you'll see here. But in that video on the top left, you can see various jigs and guides and other things in order to perform that knee replacement, just so that there are precise bone resections to make space for those implants that you're passing around. But this is people walking now under 24 hours after knee replacement. So when I first started this, I must admit, my therapists and nurses told me that it was crazy. They said that there's no way that people could do it, and that it would be hurt too much, and it would not help them, it would hurt them. So when they said that, I actually came back at night at surgery and walked all my patients myself and showed them that the patients can do it. And what happened is that very quickly this has become the norm. This has become the standard of care, because we find that paradoxically patients have less pain, are more mobile, and have better range of motion because they're using their knees faster. These are some articles explaining some of my patients' experience with this partial knee replacement, or she was actually my first patient to go home next day after surgery. So with all of those protocols, it's allowed me to advance to outpatient joint replacement. And in 2015, I became director of our outpatient joint replacement program, started a whole new program we've never had before. There are 2 sites, us in California and another one in New Jersey, where we are educating other sites across America on how to achieve this. So I've been very fortunate to be able to participate in that. I'm the only surgeon doing outpatient, partial, and total joint replacements at our surgery center. So Washington Hospital has a Washington Outpatient Surgery Center right across the hospital in Maui, and I'm doing partial and total knee replacements there, sending them home the same day. So this video here is a woman who had total knee replacement 3 hours before this video. So she's walking with our therapist, getting ready to go home. So she actually went home a few hours after total knee replacement, and this is her at her 2-week visit after total knee replacement. Home same day. So again, not everyone can go home the same day. I'm very particular. I want to make sure the patient's safe and has the right medical history for it. But the point is that the protocols, the pain management, the blood management are all in place so that people can actually go home very quickly after surgery. So I'm going to close with just a few videos. Again, a lot of this information is on this website, so feel free to visit it. This is my patient, but his wife sent it to me to tattletale on him. He was playing golf 2 weeks after surgery. I didn't recommend it, but that was him playing golf 2 weeks after. This is a lovely patient of mine. Her passion was dog agility. So she sent me in this video of her going back to what she loves, doing dog agility on her partial knee. And this gentleman, I don't know why, his passion is to be dragged by a boat on a lake, but this is him 6 weeks after surgery, going back to wakeboarding. And I'm going to end with this. We didn't talk about hip replacement, but this gentleman of mine has a very interesting hobby where he does this motorized paragliding. And so what it is he gets in this device and that big fan blows and the parachute goes behind and he can fly wherever he wants. This is him 6 weeks after hip replacement. So number 1, I want to thank you all for your time and attention. And number 2, please, I'll open up the floor to any questions that you have.
Just wondering about the physical therapy protocol following the surgery. How long is that? And if you've already been told you need double knee replacements, can you have them done at one time, or is it better to wait? If so, how long in between?
All good questions. So double replacement, double knee replacement, I do. A lot of surgeons don't do it, but in the right situation, I do it. It, of course, is 2 major surgeries in one sitting. Even though I'm showing you patients who are going home same day, next day, even though I'm telling you it's a 1-hour procedure and it's a very quick procedure, I never like to belittle the fact that it's still major surgery. And so even one knee surgery is still major surgery, but in some patients who have equally bad knees and they're candidates, they're healthy enough to have double knee surgery, then I do perform double knee surgery. So just this Tuesday, I had a female who had horrible knees, and I replaced both knees It took me an hour to do one, an hour to do the other. So she had both knees done in 2 hours, which often is how much time it takes community surgeons to do one single knee. But she went home 2 days later. So even with double knees can have a relatively quick recovery. But it depends on, again, the patient's medical status, because double knee surgery can be more stress on the heart or lungs. So if people have medical problems, maybe it's not the best, in which case I would stagger them. If one knee is worse, typically I would do the worst knee, and then as soon as 6 weeks later, I can do the other knee. But that's helps separate out the risk of having two surgeries at once. But double knees are an option, and doing them as closely as 6 weeks together is the second option. In terms of physical therapy, with knee replacement, we teach the therapy before surgery, during surgery, after surgery. It's in the binder that we provide. Our therapists teach people how to do it before they go home. When people go home, we typically will send a therapy to that patient's home to help guide them on their exercises. And then when they're driving at a week or 2 weeks, then they will begin outpatient physical therapy and do that for maybe 4 to 6 weeks. But most patients after total knee replacement are going back to golf-like activities at 6 weeks as a rough estimate. Partial knee replacement even faster than that.
In a couple of weeks, I'm having cool leaf nerve ablation procedure for temporary pain relief. Do you think that's a good idea?
Okay, so for people who don't know in this room, CoolLeaf is a technology of ablating a nerve. So what it's doing is it's called CoolLeaf because it uses a certain temperature to basically temporarily numb a nerve. So I was actually just in Atlanta as a advisor to that company. They flew me out and a handful of my colleagues from across the country to advise them on how to use that in orthopedics. So it's very fitting you asked that question. At that meeting, we were talking about its benefits. CoolLeaf, you can ablate nerves just like you can in your back or any of your other body parts. So if that nerve is responsible for the pain, it can make you feel better. Does it do anything to cure the underlying problem? Does it do anything to address what's causing the pain? No. But does it block what's transmitting that pain? Yes. But it is temporary. So we were talking at that meeting, and what we were discussing was, would that technology perhaps be beneficial before surgery? Maybe if you numb that nerve and then it was less painful after surgery, maybe that would help. Or maybe for people who have continued pain after surgery, maybe it would help. Or maybe for people who can't have knee surgery, maybe that would be a useful option. So those are all the things we were discussing. In terms of temporarily relieving pain, possibly. But it doesn't treat the underlying problem, so it's eventually going to come back. It is important that you all realize that arthritis, the natural history of arthritis, is typically its ebbs and flows. So day in, day out, it may vary in whether it's feeling good or feeling bad. So some days are good, some days are bad. But overall, it's decreasing at some rate. The good days aren't as good as they used to be, and the bad days are a little bit worse. It's when that crosses the threshold that someone says it's time for something like surgery. You don't ever have to do surgery, of course. The surgeries I've discussed here are mostly elective. But it's when it impairs your activity level enough, when you're giving up more than you want to, that you decide that it's time.
Yes, I actually have two questions. One is, where is the medical profession in terms of stem cell procedures? And two, losing weight, how effective is that to avoid knee surgery?
Good questions. So I'm going to start with the body weight first. Remember, body weight, multiplier of forces across your joints. So losing weight is helpful. I've seen patients who've lost weight and their symptoms got better. However, losing weight does nothing to treat the underlying process, right? So unfortunately, it may make the symptoms better, it may make it last a little bit longer, but ultimately that bad knee or bad joint, it's probably gonna show itself again. But in the meantime, it certainly does help. And at the worst case scenario, if someone loses weight leading up to surgery, that's less weight they're gonna have after surgery, so the recovery will be easier, so they can only win. In terms of stem cells, I touched about it briefly before. Stem cells is by far the hot topic, and you're gonna read a lot about it in the paper, because stem cells sound great. If you can harvest stem cells from bone marrow or fat, right, that's a progenitor cell which can basically go into any kind of other cell. So the thought is, can we make these stem cells become cartilage cells or something else? The bottom line is we don't have that technology. We have a way of harvesting stem cells, but we don't have the way yet of telling that cell, become this cell that we want. And even if we could grow perfect cartilage cells, imagine this dilemma. If you have that, let's say, in a paste, and let's say I paste it on the end of that knee and it's there. How do I prevent that paste from just getting rubbed away the minute the person steps on it? So there's some real challenges in not only getting the cells to be what we want them to be, but to get them to stay where we want them to stay. So it's a hot topic. There's a lot of research, a lot of money going into it, but as of right now, it's all pretty much experimental. In terms of cement, cement is the gold standard of how to put in knee replacement. Hip replacement's different. Some hip replacements are cemented and most are not cemented, but knees are different. The gold standard is to use cement. The benefit of cement is it fixes these components immediately. So before that patient leaves the operating room, it is rock solid. So patients can walk right away, whether it's cemented or cementless. So to answer your question, it gives you no benefit to be able to bear weight sooner. The one downside of a cementless device is you do have to wait for the bone to grow into that implant to make it secure. So in very rare circumstances, the bone may not grow in. Just like a fracture may not heal, bone may not grow into a cementless device. But with cement, you know it's rock solid right away.
When you're doing the total replacements on the knee, do you try to save the patella?
Yes, so in the...
And if you can't save it, does anything go in its place?
Oh, another good question. So I did not mention that the patella is saved in all cases. What happens on the back of the kneecap is like that model that we passed around, the partial kneecap replacement. The kneecap is preserved, the backside is cut flush, so a few millimeters removed, and a plastic button glued to the back of it. That way, it's plastic on metal when it glides. Because if we don't resurface it, it's going to be cartilage on metal, and you know what's going to wear out. The kneecap's going to wear out. So we resurface the back of it. But in all cases, that kneecap is mostly preserved.
The sizing, since everybody's a different size, how do you, are these off the shelf and you cut them to size, or do you get them measured for each patient ahead of time and just order them?
And so people love to ask about sizing. Yes, every knee in here is completely different, and even your right knee might be a different size than your left knee. So how do we deal with that? We've looked more and more in ways to optimize the personalization of these implants. There's only one company that actually will make an implant, a metal implant, custom to the individual's knee, but it's not, as great as it sounds, it hasn't proven to be really clinically beneficial. It costs more, it takes longer to make. Unfortunately, it hasn't taken off just because it hasn't proven to do what we thought maybe it would. But it's probably because the implant companies have made so many different sizes that you can basically personalize it on the fly. So what happens is when I have a surgical candidate, I have their x-rays, I'm able to put them on the light board and use templates to measure what size they'll be. So before that patient's even in the operating room, I have an idea of what size they need. On the femoral side, for example, there's about 24 different sizes that I can pick and choose from. Different sizes, heights, and widths. There's about 12 different sizes on the bottom. So I can mix and match those. So when I'm in the operating room, I know what I templated, what I think it's going to be based on x-ray, but then I have various sizers. So I can size the knee in the surgery to the exact, and figure out which will fit them best. And then after that, I have metal trials, is what they're called. They're implants that I put into the knee and test the knee before I cement in the real ones. So I have various checks and balances to basically individualize it for the patient.
I've seen a lot of literature lately that it said in most cases, if you're going to get a partial, you should probably go for the full because, like you said, the partial only apparently lasts 15, and in a lot of cases 10, and a full lasts 20. The second question is, there was in the Mercury News about 6 months ago, there's an article where a surgeon used robotic assistance in cutting. Just your opinion.
Good questions. This is a good group. You guys are all asking very good questions. You're keeping me on my toes. Partial knee replacement, again, has many advantages over total knee replacement. And when I trained in Chicago, that's where I did fellowship, I actually learned from one of the nation's experts, and he's actually the one who did President Bush's 2 partial knee replacements. That's why we learned the technique and how to do it. They also happen to actually have the longest published data, the longest research on partial knee replacements. And what that data shows is in the correctly selected patient, done the right way by the right surgeon, they've followed patients out decades, and at 20 years, over 90% of partial knees are still functioning very well in their hands. So partial knees done well can still last decades. And with all those benefits, that is a huge advantage. Like I said, let's say in that minority of cases, the partial knee replacement fails. Usually the partial knee replacement doesn't fail, but arthritis progresses elsewhere. Over 20 years, that could happen. But what's good to know is that a partial knee replacement done by a surgeon who specializes in it, and the knee replacement surgery, if needed, that follows, if done by that same specialist, the results show that that's the same as getting your first total knee replacement then. So what that means is if you're 50 and you have a partial knee replacement and you're 75 now and you need a total knee replacement, that's like getting your first total knee replacement at age 75. It burns no bridges, as opposed to your first total knee replacement at 55 and then your second revision one in your 70s. So there are benefits of the partial knee, and again, it can be very durable, equal to total knee replacement in many ways. The computer. This is sort of like the gadgets and the lasers and the stem cells and all these things you hear in the news, and it's in the Mercury because people are interested in robotics. I didn't bring up these slides, it's in a different talk, but technology, we live in Silicon Valley. Everyone just saw that big Apple release, right? And everyone's probably pre-ordered their phone already. We live in the center of technology, and we're basically groomed to believe that the next best thing's got to be better. That's not true in medicine. So in medicine, if you know something works, you want to make sure it has 20-year results, because that's the standard of care. Someone could come out with the shiniest new component or the best, fastest computer, but until the results of that show, it lasts 20 years, by definition, you can't be any better than standard. I'll give you one example, metal-on-metal hip replacements, right? You've all heard of it. A few years ago, everyone thought that was a new thing. It's less wear, better stability, better for patients. But what happened? A couple years ago, Johnson & Johnson, one of the companies, had to recall 100,000 of them because it failed. And these were done in young people who only had them for a few years. So even though something looks better in the lab or something looks better on paper, until you do it in a person, because medicine's different, you really don't know how the durability will be. So robotics is interesting. It's fun, it's a toy. I mean, surgeons like it, just like they use robotics in prostate surgery or other things. But what happens in a lot of these situations is these expensive robots end up sitting in the hallway collecting dust because it takes longer. There's sometimes downsides. So there are some things on the internet if you look. What if you're in the middle of a computer surgery and the computer suddenly malfunctions or doesn't work? Are you going to be able to finish the surgery? Maybe not. But when the results are very good with joint replacement, again, if the results are this good and the margin of improvement is relatively small, the question is, does the computer actually make it better, or does it just add new chances for error? And with navigation, computers, custom joint replacement, all these things, time often shows that it's not as good as it's been promoted. That's a great question. Well, you guys passed it around and you felt the weight of it. Some people ask me, is this going to add weight to me? And I usually respond and tell them, if you want to blame those holiday pounds on me at the end of the year, you can go ahead and do that. But no, you won't feel it because it's in your body, so you won't really notice one leg's heavier than the other, for example. And in terms of feeling it, remember with the partial knee, because you keep every ligament, that knee is going to feel more, quote unquote, normal to you than a total knee. But total knees still work wonderfully well. But potentially you might feel a little clicking at times. You might feel a little bit less stability than your normal knee. It's not a 16-year-old knee. It works very well, functions very well, but you may feel some differences, but it's typically not noticeable.
I didn't really understand what you said about compromising the ligaments in total as opposed to partial. I know I need a total. Do you sever the ligaments? I didn't understand the difference.
The total knee replacement you passed around, remember, it goes all the way across, right? It has to go from all the way to the inside of the knee to all the way to the outside. And what lives in the middle? That anterior and posterior cruciate ligament. So the only way those devices can fit is if they're sacrificed. So in almost all knees, 99.9%, the ACL is sacrificed. In variable amounts, the majority, the posterior cruciate ligament is also sacrificed. Now the total knee it has a mechanism to recreate the function of the posterior cruciate ligament, but it's a mechanical, right, artificial mechanism. And the anterior cruciate ligament is not greatly recreated, which is why it can feel a little bit looser. Now that being said, total knee replacements work great. And they're still stable and people can still, but that's why they're not playing soccer or cutting sports or things like that. But with a partial knee, those ligaments aren't even touched. That's the difference.
First of all, scheduling seems like you're very busy. Let's say after initial consultation, evaluation of tests, x-rays, how long are we looking at to be on your calendar?
Hopefully we're able to be very responsive. The thing I'm trying to work with our staff is we're trying to be as responsive to our patients as possible and get them in as soon as possible. See them, and then a lot of the scheduling depends on the patient's medical history. So some of my patients have heart problems, lung problems, medical issues, diabetes. You obviously want to optimize that before any elective surgery because it's not an emergent surgery. Don't have to do it right away. You want to be as healthy as possible before surgery. So those patients, it might take a few weeks or even months to get them optimized. If someone comes in and they're very, very healthy and have no medical issues, they're going to get scheduled much faster, of course. So I typically do about 7 to 8 joint replacements in a day. So yes, Tuesday I did 7 or 8, and Thursday I did 7 or 8, and then they all went home the next day. So I can get to a lot of patients quickly, but there's still, you're right, is a lag. It's probably somewhere around the 6-week time frame, because I'm also doing some of these at the outpatient joint replacement or the outpatient center. So I have places where I can shift people and try to help them sooner. Thank you again, everybody.
Okay, so